ये कल बच्चों को आवाज भी नहीं जा रही थी। ये अनम्यूट तो नहीं किया था?
को म्यूट कर दिया, आपको अनम्यूट, आपकी आवाज जाएगी, उनकी आपको नहीं आएगी।
ठीक है, नहीं तंग करते वैसे। अगर आप
नहीं, अगर कहे तो बता देता हूँ उनको।
थोड़ी देर अनम्यूट करके देखते हैं कि कैसा रिस्पॉन्ड होता है। मैं अभी स्टूडेंट्स को
ठीक है।
Hello, Zoya Rana, can you listen me? Are you there? Mohammad Shehzad, are you there? Saran Ghani?
Yes, sir. Yes. Sir, I am present.
Okay.
Yes, sir.
Shehzad, are you there?
Yes, sir.
Okay, should we start the session?
Yes, sir.
No, okay, I'm going to unmute all the participants so that there should be no disturbance. करते हैं क्या unmute? Mute कर दो सारे students. Well, Bismillahirrahmanirrahim. Yesterday, we started talking about the anatomy and physiology of the diseases of liver. In fact, you should be very well aware of the subject of anatomy and physiology because you have to apply the knowledge to pathology, and the knowledge of pathology is required to develop good concepts to apply medicine and surgery. Yesterday, I talked about many of the functions of liver, and I will just revise them in 2 minutes, and that is the metabolic and synthetic functions. The metabolic means metabolism of carbohydrates, metabolism of proteins, metabolism of lipids, HDL synthesis or albumin synthesis, coagulation factors. We talked about the glycogen storage when there is hyperglycemia, and lipogenesis or lipid storage when there is hyperglycemia, and vice versa when there is starvation or there is hypoglycemia. I told you that there is glycogenolysis, gluconeogenesis, and lipolysis or breakdown of fats. Fats means triglycerides. The triglycerides are the second good source of energy and after glucose. So if there is hypoglycemia and glucose is not available, so what happens is the liver starts lipolysis. And lipolysis means breakdown of triglycerides. Cholesterol enters into amino acid pool, and the fatty acids, they are the source of energy. So this is what happens, and that is one of the factors. If you remember diabetes mellitus, the cells, they are deprived of glucose, so there is starvation of the cell. So you can say in diabetes mellitus, although there is hyperglycemia in circulation, but when you talk about the cellular level, intracellular hypoglycemia is there. So diabetes mellitus is a disease. When we will study endocrinology, you will find that there is hyperglycemia extracellularly. That means in the circulation there is hyperglycemia. Because of the deficiency of insulin, whether it is absolute or relative, the glucose is not transported into the cell, so there is the cellular starvation. The glucose does not reach the cells. The cells are starved. So what happens is there is lipolysis and there is fatty acids increase. So the pathophysiology behind the diabetes mellitus is same almost as it is in hypoglycemia due to starvation. So when the cells are starved, lipolysis is there in the liver, fatty acid is increased, so there is diabetic ketosis, that is ketone bodies increase in circulation. And when the pH changes, that is diabetic ketoacidosis. So I'm not going to talk about the diabetic ketoacidosis at this level. I'm only telling you that the liver, the metabolic functions of the liver. I told you last day as well that liver is a big organ. It has got a huge reserve. So the lobules, the reserve lobules, they keep on doing their function even if there is a lot of damage to the liver. So mostly in hepatitis, you don't find hypoglycemia or you don't find disturbed metabolic functions except the level of albumin and the prothrombin time, that's the coagulation factor 2. So these are the things which are affected when there is a chronic liver disease. There is a lot of damage of liver and it's chronic in nature over a period of months or years. So finally, the patient develops hypoalbuminemia because of which, for example, in cirrhosis, there is ascites because of, or there is a development of edema around the feet, and that edema around the feet or ascites, or the ascites is the collection of fluid in the peritoneal cavity. So that is because of hypoalbuminemia, and it is when a lot of liver is, the hepatocytes are replaced by the fibrous tissue, for example, in cirrhosis. So that is CLD or chronic liver disease. So in chronic liver disease, there are chances that the metabolic functions or the synthetic functions. Synthetic means synthesis of prothrombin. So synthetic function, whether it is albumin or it is prothrombin, that is disturbed in chronic liver disease, not in acute liver disease. So over a period of months or even years, maybe 30 years, you might have edema feet and ascites, or you might have prolongation of prothrombin leading to bleeding disorders, bleeding tendency, easy bruising. The person scratches because of the deposition of bile salts or bile acids in the skin, but once you scratch, there is itchy skin. I told you last day. And when you go for itching, there is easy bruising. So you can have bruises over the body. More than that, even varicosity of veins, a patient may have epistaxis, but that is in chronic liver disease. So leaving aside all these metabolic factors, I was telling you that it's albumin, hypoalbuminemia, or prolongation of prothrombin time, which is a fat, it depends on the vitamin K, and which is a fat soluble vitamin. I'm not going into that detail, but bleeding, easy bruising, bleeding, hyperalbuminemia, edema feet, ascites, you can find these symptoms in chronic liver diseases. Well, don't worry, you will be taught all these diseases in detail by Professor Naveed Qureshi, one by one. She will take the diseases. I'm just giving you the preview or overview of liver and what happens in the laboratory and how you reach a diagnosis. I told you yesterday as well that I just want to make you familiar with how to solve the scenario and how to think about the scenarios, solving the scenarios in SEQs, MCQs, as well as in hospice. So it's a thought provocation only. These two sessions are how to provoke your thought process when you want to reach on a diagnosis. So initially you have to think the anatomy, physiology, and based on disturbed structure or disturbed physiology or functions of the organ, you can only think of clinical features of the patient. And once you know about the clinical features or history of the patient, then you have in your mind how to elicit the signs, what signs you suspect you. I mean, if there is a hepatomegaly, obviously you will not go to towards looking for examination of throat. You will directly touch the right hypochondrium to see whether there is hepatomegaly or enlargement of figure and how much liver is enlarged, whether it is 1 finger, 2 finger, or how much hepatomegaly is there. So the third thing is then you go towards the investigation. I told you yesterday, starting again after this, that is the bilirubin. In fact, the liver has got the conjugation, the mechanism involved in bilirubin metabolism is that it has got the capability to conjugate it. Initially, it is not water soluble, but after conjugation, the bilirubin becomes a water soluble pigment. So going forward, so there is no need to worry about the pre-hepatic jaundice, which includes all those causes which are it's a baby of ABO-RH incompatibility, or baby in which there is infective erythropoiesis, or a baby having megaloblastic anemia or sideroblastic anemia, or an adult in which there is a sickle cell anemia, or any other. For example, I told you yesterday as well, hematoma, or a large amount when it is resolved, when it enters into the blood, the heme portion, finally you can have some level of raised bilirubin in patients who have got large hematomas. So there's no need to worry about even the little increase of bilirubin, whether it is because of any unconjugation, decreased uptake because of enzyme deficiencies which are congenital or genetic disorders, or decreased conjugation, as I told you yesterday, that there is Dubin-Johnson syndrome or Rotor syndrome, in which there is a decreased conjugation. So interference into conjugation or uptake or breakdown, forget about that. Mostly they are not your problem related to hepatology. But more so it is the यार ये नेक्स्ट स्लाइड पे कैसे जाना होगा इसमें आपको कल तो यहाँ आ रहा था कसर ये कसर क्या कसर दोबारा बताइए ये कसर की तरफ कहीं पे कसर रख के माउस के अगर ना आई एम सॉरी डियर स्टूडेंट्स एक दफा सिर्फ इस पे क्लिक करते हैं अच्छा वो अगली पे चला ये अगली है ये बैक है ये बैक अच्छा. So moving forward, I told you don't worry about, you have to think about the post-hepatic and the hepatic jaundice. Hepatic means when the cause of jaundice lies with the liver. So you will see total bilirubin is raised, conjugated or unconjugated bilirubin, certain conjugated processes going on. Some form, when the load is there, but the reserve is less, or hepatocytes are less in number. So when the proportion is disturbed, you can see that the whole bilirubin, which is coming from heme, some portion of that remains unconjugated. So it all depends on the amount of cells or hepatocytes or the lobules, number of lobules which are affected. So obviously there is unconjugated as well as conjugated bilirubinemia. So both are raised. The total bilirubin is raised and the components of bilirubin, they're also raised in the blood. What about urine? Obviously, you see over here hepatic is dark in color, urine is dark in color. There could be bilirubin. You may find the report plus minus, urobilinogen plus minus, and color of the stool is also dark. So this was about bilirubin. Once you come across a case in which there is bilirubin is normal, but patient comes with a report showing that the alanine transaminase or aspartate transaminases, these are the enzymes, they are increased. This is the normal values, but if it crosses the normal values in men and women. So this is 4237. AST is a little less than ALT, but forget it. You just think about it as close to 40. So 40 units per liter, or you call international units per liter of AST and ALT. So all these enzymes in adults, talking of adults, the patient may come to you with a report with a rise of ALT and AST only. So bilirubin is normal. Sometimes the patient comes to you with a raised bilirubin along with raised ALT and AST. Sometimes there is a patient which comes with a rise of gamma GT only, raised gamma GT. So I told you yesterday also there are more chances that the patient has got alcoholic hepatitis. You must take these whether the person takes alcohol or not. Well, alkaline phosphatase, as in children, you can find it over, it's almost 3 times more. So normally, as the second source of alkaline phosphatase is the bones. So obviously, if the age of the patient is lesser than 12, there are chances that normally, if everything is normal, only alkaline phosphatase is this, immediately think of the age of the patient. If the patient is lesser than 12 years of age, you can place the patient that you are a normal person. And it's the clerical mistake. Some reports, some laboratories, they do not give the values of adults and children separately, although it's their responsibility. They should provide the report. keeping in mind the age. Now is the day of media, and obviously softwares are there which software itself picks the age and will give you the normal value of the child. Somehow, don't worry about that. So now the question with you is, you have now reached on a point that, keeping in mind the history and some investigation, you have reached on a conclusion that the patient is suffering from some disease of liver. So now is the question, and that next question in your mind is, what can be the cause of the liver disease? Once you reach on the cause of the disease, then you can manage the patient accordingly. So, how to reach on the cause of the disease? The most common diseases which comes to your mind once you think of that there is a person who is suffering from hepatic disorder or disease of liver, one cause is viral. So viruses, they lead to inflammation, whether acute. There are certain viruses which takes the liver to chronic liver disease. So it is at present, we are not talking about acuteness or chronicity of the disease. We are talking about the liver can be infected with viruses. I'm not talking about virus. Which virus? So viruses is one cause which can lead to acute hepatitis or chronic hepatitis. So if we enumerate certain important diseases, then we will go on to some laboratory investigation at a later stage. So viruses, the second commonest cause in which there is hepatic disease, that is drug induced. So if there is viral markers, they are normal. There is no clue laboratory is providing to you. There is no information. Laboratory is not providing you any information related to viral markers. And the patient but have got the liver disease. The second thing you must ask, are you taking any drugs like antituberculous therapy or chemotherapeutic agents? Or there are many other drugs. The third thing is, after if you enumerate the importance, I will just encounter with you only few important diseases because there's not much time for me. So viruses, drugs, then alcohol, then diet, fatty liver, then there are certain substances which are deposited like hemochromatosis, iron deposition, copper deposition, Wilson's disease. Also, there are certain things which are deposited in the liver and liver is disease. But all these diseases, there could be a patient which you can label as patient of chronic active hepatitis. You can label him as persistent hepatitis. You can label the patient as patient of cirrhosis, patient of hepatocellular carcinoma, patient of hepatocellular failure, or any other. So there may be intracholestasis obstruction, or there may be extracholestasis obstruction. So initially, you have to look for LFTs or liver function tests, and biochemical markers for the liver function tests are bilirubin, then transaminases, which includes ALT, AST, and gamma GT, gamma glutamyl transpeptidase. That is also minor transferase. And the third is alkaline phosphatase. So these three things will help you to think about whether it is intrahepatic or extrahepatic. So we are only taking two components, that is hepatic diseases, and if the bilirubin still is raised and there is liver is not involved, so there could be post-hepatic jaundice or something wrong with not with liver but beyond liver. So initially we're talking about, so this was the list which I have given you about the clinical diseases, the names which you come across in your clinical practice or in your subject. So viruses, amongst the viruses, hepatitis viruses usually are as A, B, C, D, now there's E, even F. The more important are A and E, they are foodborne, and B and C, they are bloodborne. D is the delta virus, which is the genome of delta virus is a mutated genome of hepatitis B virus. So first of all, we take the hepatitis A virus, hurriedly going on to if this is a graph which shows you that if you suspect, if you suspect that the patient is suffering, how do you suspect that the patient is suffering from hepatitis A virus? I'm telling you, it's not much, but more so the hepatitis A virus or a foodborne virus is more commonly seen in children which are coming from school and they eat something which is having A virus. I tell you one thing, hepatitis A virus more commonly, not that always, but more commonly is seen in children, but it may be seen in adults also. But in hepatitis A virus, the important thing which your mind goes towards it, that is, the incubation time is only 15 to 45 days. So for a month, the person says that there's a little weakness and there's a feeling of unhealthy. But the examination as far as laboratory analysis is concerned, it was also found in feces. Nowadays, there is a lot of literature available on coronavirus. So coronavirus, let me tell you about as a pathologist, that species is also one of the specimens from where you can also isolate coronavirus. Same is true for it, but don't think that it's a foodborne. Still, a lot of literature or research is required on coronavirus. It's only the initial phase, but maybe after a decade or two, when it will be your time of teaching. So you may be more knowledgeable about coronavirus. But feces may say you can isolate coronavirus from fecal matter, but that is not recommended in fecal matter isolation because you can see over here that fecal hepatitis A virus is only found in early phases and it gets down before 2 weeks of illness. So 2 to 3 weeks of illness. So it's of no use to. Number one. Number two, fecal analysis for hepatitis A virus is never required because you have to perform the test for 3 times. It's a huge specimen. So I'm taking a specimen from a portion of fecal matter from one place and then from other place next day, third place, another day. So it's a laborious exercise which that may not give you any fruit, or it will be fruitless to have. It is just for the theoretical purpose. The only thing is there is an acute disease which almost the most common question which is asked by the mothers or the parents of the child, and sometimes when it is seen in adults, the question is how long it will take myself to settle down. So it is 3 months almost, 6 weeks to 3 months. If you take the mean or the average, that is the disease which takes 6 weeks to 6 weeks to 12 weeks. So that is immunoglobulin IgM HAV, that this is antibodies. So antibodies against hepatitis A virus are 2 types, immunoglobulin M or immunoglobulin G. IgM is seen in usually in acute cases, but IgG also starts producing once hepatitis A virus infection is there, and it remains throughout its life. IgM drops down gradually after maybe another 12 weeks, so that's after another 3 weeks. So after 6 months, if you go for IgM analysis, that is a useless investigation to be asked. It is the responsibility of every doctor, yourself, when you will become a doctor or a house officer or a registrar or even the consultant, that one should advise only the test, keeping in mind the pocket of the patient. No patient, whether it is in Pakistan or it is abroad, is very, very rich. So you have to be very careful once you need to advise investigations. So after going for LFDs, if you think of that the person is having hepatitis A virus, my suggestion is there is no need to go for investigation. You depend on your clinical sense, or only 2 times, initially and then after 6 months. After 6 months, only IgG. IgG becomes, you can say, prevents you. So it is a preventive immunoglobulin IgG. Very much discussion is there on the social media about passive immunization in case of coronavirus. So if immunoglobulin G is there in cured or healed patients, and the research tells you that IgG is helpful in prevention of a disease or cure of the disease, then only you can justify it. So a lot of hue and cry about passive immunization in social media is still under trial. It may later on prove to be useful, but in cases of IgA infection, obviously once the person or the child or an adult gets an infection or hepatitis A virus remains, you can say this is called a way of active immunization leading to passive. So the patient has got the immunoglobulin. If the antigen comes against A virus, the person will deal with it. So you will not get second attack of infection as far as hepatitis A is concerned. So moving on to hepatitis B. There is a long list of investigation. Remember, hepatitis B surface antigen, hepatitis B surface antibodies. This is antibodies, or anti-HBs. This is anti-HBs. So anti-HB this is I'm sorry, the cursor is not. This is anti-HBs, surface and antibodies against surface antigen. So there are three types of antigens which are present in hepatitis B virus. One is called surface antigen, the other is called core antigen, the third is called envelope antigen. Similarly, there are three types of antibodies against these antigens. So hepatitis B surface antigen, against this there is antibodies against surface antigen. Hepatitis B E antigen, there is antibodies against envelope antigen, that is anti-HBe antibodies. Similarly, against core antigen, there is core antibodies. So there are three types of antibodies, three types of antigen. So you have a long list, and this is very expensive. It's almost costing 12 to 13,000 rupees if you advise all these investigations. So which investigation should be provided? If there is a patient, you've come across a patient of hepatitis B. So hepatitis B surface antigen positive patient, a little clue you can get it from here. From here, this is usually if a person gets hepatitis B infection, the patient recovers in most of the cases, and the patient has got antibodies which are present. So anti-surface antigen against that antigen, the antibodies are present, and the presence of those antibodies, if antigen is not present, if there is no viremia or there is no surface antigen, suppose you advise a patient for hepatitis B surface antigen and hepatitis B surface antibodies. Surface antigen are not present, but antibodies are present. That means the person has no virus. If there is no virus, the person will not pass any virus. Usually the question asked to you is sometimes that I was hepatitis B positive, but presently I am not. I don't carry any antigen, but I have antibodies. Should I give transfusion? Your answer should be yes, because there is no virus in that. If there is no virus, you are not transferring. I'm sorry. You are not transferring any antigen. Antibodies are there, so there is no harm in giving transfusion. Preferably, you should choose a person who is a healthy donor and a good age, not in age, a person of my age, because there are many other reasons. So healthy persons, blood transfusion is better. But if there is no available transfusion and the person says, I was a patient of hepatitis B, I had once upon a time, 20 years back, hepatitis B surface antigen positive, but presently I do not have any virus. My result is that hepatitis B surface antigen is negative, but antibodies are there. Can I give transfusion? Yes, the answer is yes. But because there is no virus, there is no transmission, you are only transferring immunoglobulins. And there is no need of to tell immunoglobulin you give. There is no harm about the immunoglobulin, you know it. The second thing is the rare chance are there are infection, and out of those infection, most of the cases they do not develop liver damage. Antibodies are present, and antigen is also present. This patient cannot transfuse blood as virus is there. So if there is a patient who has got hepatitis B surface antigen present and antibodies present, is not fit for transfusion. But he is a carrier. He is carrying the virus, he is carrying the antibodies also. He do not have any liver damage. LFTs are not disturbed. If LFTs are not disturbed and the patient has got hepatitis B surface antigen positive and antibodies are also present, so you can say that that person is a carrier. In very, very few cases, there is a damage, and damage is when the damage is there, viremia is there, antibodies are there, damage is there, liver functions are disturbed. This is another example. So coming on to next, which test you should advise after that. The best thing is you just take the history. Suppose the patient came to you with a history of maybe 16 years. So place your foot over here and make state over here. And in this line, whatever the investigations are, you can advise the patient those investigations. Never ask for the whole hepatitis profile. That will be a big burden on the pocket of the patient. You can save the money for that instead of treatment. Treatment is usually you give interferon therapy. So this is hepatitis B, and then is hepatitis. This is a delta mutated virus. This same history. Hepatitis C virus, obviously, very few cases. It's reverse condition, as it is in infection due to hepatitis B is different from infection due to hepatitis C. Hepatitis B, usually either the patient recovers fully and there is no antigen, only antibodies are present. That is the best patient. Sometimes the patient is a carrier. He carries hepatitis B surface antigen and antibodies, but liver functions are not disturbed. That person is placed in the group of carriers. There is another third group in which there is liver function disturbed. That patient is a dangerous patient. When the person who suffers from hepatitis B and has LFT is disturbed, usually develops into fulminating hepatitis and hepatocellular carcinoma. Hepatocellular failure. So hepatitis B is more dangerous, but it is only and only present in very few cases. That is 1 out of 10. Vice versa, the reverse condition is hepatitis C virus, and that is the only 10% they recover, and 90% patients they transform into cirrhosis. So you can find it over which investigation should be provided if you face a chronic liver disease case and you suspect the C antibody. Remember one thing. When you, most of the laboratories, they perform anti-HCV. So when you use the word anti, that means antibodies to hepatitis C. When we are talking about hepatitis B surface antigen, we are talking about antigen. We are talking about DNA. So we are talking about DNA virus itself. So you are detecting antigens. Whereas when you talk about hepatitis C virus in most of the parts, you write viral markers. Remember, the laboratory will give you a report of hepatitis B surface antigen and anti-HCV. So that is antigen, that is antibodies. So as far as hepatitis C infection is concerned, you ask for antibodies. And when you ask for antibodies, you are getting an indirect evidence of previous exposure. So hepatitis C virus usually takes you towards chronic liver disease, and the laboratory reports you anti-HCV antibodies, whether they're present or they're not present. If anti-HCV antibodies are present or anti-HCV are present, you can say that simply means the patient had an exposure, and you should go for further investigation. And which further, I told you that it's only very, very few percentage of cases of hepatitis C virus which become carrier. Mostly the people, they become disease, they transform into chronic liver disease. I don't want to go into the detail of this. Well, the only thing, time is too short. In post-hepatic jaundice, you can find these conditions, and if the rest of the slides you can see from LMS, and you can go through them. The only thing is in cirrhosis of liver, if it is primary biliary cirrhosis, that is biliary duct cirrhosis, not cirrhosis of hepatocytes of liver. You go for anti-mitochondrial antibodies detection and detection of IgM, Well, extrahepatic cholestasis, I told you last day as well, that there are chances that the post-hepatic obstruction, as we're talking about, could be because of stone inside or inflammation of the bile duct or pressure from outside. The last point which can help you to, which you need to remember, persistent pain favors carcinoma of head of pancreas, which is outside. The pressure is from outside. Persistent raised bilirubin and disturb your function. And if you think that there is no liver disease, the disease is beyond the liver. So post-hepatic hepatitis, if it is persistent, pain is persistent, transaminases rise is persistent, and the condition is persistent, weight loss is there, it is deteriorating, think of carcinoma of bladder. Go for CT scan and ultrasonography. But if stone is there, you usually have colicky pain. The patient comes to you with colicky pain. Liver function tests and transaminases and bilirubin is also fluctuating. Sometimes it is raised, sometimes it is normal. So fluctuation, colic, if colic is there, bilirubin and LFTs are raised. If there is no colic, the patient is normal. So stone is suspected. Remember, if you want to differentiate between cholestasis due to a stone or obstruction from within and obstruction from outside, these are the few things clinically as well as laboratory which can help you towards that. So I'm sorry, time is over. Thank you very much, and see you soon. Goodbye. He comes.